Welcome, dear viewer, to UBC TV and Amande Akol Amazima. We are still looking at the COVID-19 pandemic still with us, and definitely as government and also other well-wishers trying to caution us in one way or the other so that we can keep safe. Now today we look at the access to medical oxygen during COVID and beyond. Today we're really going to focus on oxygen, and with me in studio is Doreen Kachompoga, who is an engineer from the Ministry of Health. You're welcome.
Thank you very much.
Yes, we also have George William Barije, who is the Regional Technical Advisor for Perth. You're welcome.
Thank you very much.
Yes, when we talk about issues of oxygen, of course, all along we thought that oxygen is God-given. It's one of the gifts we are given, because they say the greatest talent, the greatest gift is the gift to live. But now, and you cannot live minus oxygen. But now we are COVID has brought a new term to us that now you need to get oxygen. We don't know from where. Now let's look at what is the current state of medical oxygen in the country.
Well, thank you very much. Oxygen is still is still God-given. It's our gift from God, surely. And even when we make the medical oxygen, our raw material is the ambient air that we breathe on a normal. Right now, the reason why oxygen has come to the top is because now we have moved from just oxygen to calling it medical oxygen. So what is this medical oxygen story that is building up? Medical oxygen is the ambient air that you have, and then you remove the nitrogen and any other inert gases, and then you clean it, remove all bacteria, remove all oil, remove smoke, remove every other impurity, and then you're purely left with that 21% you have in the ambient air. We take it and keep taking it and keep taking it, and then concentrating it, and we put it in a cylinder and compress it further so that we make it completely available. So when you have a cylinder, it is compressed air in there, full oxygen, fully pure, so it can vary from 92 to 99, even up to 100, but it is purely concentrated oxygen. So that's the one we are calling medical oxygen. So yes. So why we've always had a need for it in our treatment and healthcare services. We've always had a need for it. We've had essential services that we use it for. For example, post-theater, we use it for asthma, pneumonia, so many other cases that we use medical oxygen. Just to break it down further is on a normal human being, inside your body are red blood cells that absorb this oxygen and take it to your whole body, to your whole system. So they take it to every cell in your body, because every cell in your body needs energy. And now the oxygen is what, it uses the oxygen to make the energy in all those cells. Because all your cells function. They all each have a function different in different places, but to function, they need energy, and to get energy, they need oxygen. So that's what happens in your normal body. So when COVID comes, it goes straight to your lungs and affects your ability for the red blood cells to absorb this oxygen. Okay. So in comes medical oxygen at high concentrations. What we do is we are exposing your whole lung to a high concentration of, say, 90% or 99% at a small flow rate, of course, so that what your lungs have to do is just absorb, and they don't have to filter out everything else. So the red blood cells absorb this high concentration. So what happens is eventually the damage because of COVID progresses to a point where even your red blood cells are not able to take in as much oxygen. So now we want to push it into your red blood cells. And so we give high flow rates, and then your red blood cells take in as much as they can to save your body from shutting down. So that's the story that has brought medical oxygen to the top.
Well, thank you very much, Doreen. Yes, we go to George, I think, from the private sector, from the civil society, because ideally you observe what is going on and perhaps engage or advise government accordingly. Now, what has been your observation with medical oxygen? Is government doing enough?
Yeah, thank you very much. I think for sure we have to commend the government that the government has done, I can say, has tried to do its best, given the situation in which we are in. We have to remember that this is a global pandemic. So there are a lot of things that are taking place, not only here in Uganda, but even in other countries. And given the fact that this is a new disease, that every day we learn new things. So there are a lot of things which have been involved in this. So we cannot be surprised that we are facing actually some of these crises, like for example, getting access to oxygen being a big issue. However, I think what needs just for it to be done is making sure that we have try our level best as the country to have to have a coordinated way on how to minimize some of these issues that are actually coming with the challenges actually that we are facing. You're aware that as we are struggling to get oxygen, also other countries are struggling to get it. And unfortunately, sometimes we find we have to get the same resources. Then the other thing is that as we know that this, as Doreen explained, that this is something, oxygen is a life-saving commodity which has been existing. Now the issue of, it is like if you have the demand and you cannot be able to meet the supply. And the whole issue is because this is it came in just last year as a pandemic, which comes just sort of like an emergency. Therefore, you have, unless you do things different or you get any other assistance, so the chances are high that you are likely to get that shortage. And I think this is what actually we are experiencing. So I would say that my observation, like from someone outside, I think there are key things that we need to be able to do. Like for example, we may have done the best, but I think there is room for improvement. And it could be like, for example, how do we support, for example, the health facilities, the private health facilities? Because at the end of it all, it is the mandate of the government to provide health care services to all its citizens. That's actually like the basic. Then, but we have the private sector, we have the civil society who actually complement or supplement government efforts. Now, part of what I was bringing up, going back to the question which you have put forward, that what do we see, what could be some of the issues? So issues, for example, how do we support, how have the health facilities, the private health facilities been supported in this? And this maybe would have been an issue for proper coordination, like for example, proper coordination in terms of managing the supply chain. You're aware that this is, as you say, it is a life-saving commodity. If we have, let's say, the coordination by the ministry, so that these private facilities can actually be able to access this oxygen with ease. So I'm thinking that that could maybe also reduce, for example, on some of the costs that are at the end being slapped to the patients. The other thing is, it's good that actually we are now coming up and having most of the taking the initiatives to have or to be able to be reliant in terms of production, in terms of managing all
Well,
that.
if you can hold on to your point, you've actually brought in the issue of production.
Yes.
Because of COVID-19, Uganda is actually joined the list of the countries that are medical oxygen stressed. So let's look at how COVID is, how medical oxygen is manufactured. In Uganda, who are actually the manufacturers?
Okay, that's a very good question. Fortunately for us, because we've had a strategy going for a few years now, because World Health Organization included oxygen, medical oxygen, as one of the essential drugs. So medical oxygen is essential in our healthcare services. So with that, we picked that up, and then we put oxygen plants in all our regional referral hospitals. So all our regional referral hospitals have oxygen plants. There's of course a bigger production in Malago because of its specialized care. So we already have those plants now. What happens is before COVID came, we were able to use those small plants of ours to take care of our oxygen need down up to health center floors.
Because the demand was not so much as it is now.
Because what a patient would need on a normal, on a daily, is 2 liters, 5 liters per minute. At worst, 10 liters per minute. In comes COVID, and it wants life. It takes 20 liters, 70 liters, 50 liters per minute.
Per person.
Per minute, per person. Per minute, per person. So you can imagine how much it is sucking. So now we have, when we have all these patients, that demand went it was very aggressive. Fortunately for us is we partnered with so many. We partnered with the private sector manufacturers. We partnered with other organizations to supplement our oxygen demand. We were already taking care of as much as we could, but when we went to that level of stress, we partnered with so many of these manufacturers. I wouldn't want to mention one and forget the other, but roofings has been key, and so many others actually. And so they fill our cylinders, so we are able to meet the need in our hospitals. Other organizations have come in and donated cylinders, donated the oxygen therapy accessories that we need to use. So that's how we have been managing the demand. Well, the stress came because we had a second wave and the numbers went so high. But it was very manageable, very controlled, because we partnered with so many. Everyone was in this with us, bringing cylinders. Bring your cylinders, we'll fill them for free, and so on and so forth. So that's how we've managed to control the second wave, and actually we hope to get out of it.
Yeah, if I come back to you, George, see, when we were young, we used to be told of free things like water, but especially in the villages, when we came to town and grew up, find that you have to pay for water. Now we all know that really oxygen is something that is given. Now here we are, we have actually to pay for it. Now let's look at the cost.
Okay.
The cost of this medical oxygen. We find that actually it is too high for a common mwananchi. What ought to be done?
I will just defer some part of the question to Doreen, because she may actually be able to understand like what is involved.
But from the civil side point of view, because you are also in better position as observers to advise government.
Sure. As I said earlier, I think what is happening is that the moment there is demand, and it surpasses the supply, then you definitely going to see a rise in the price and in the cost. And that's actually what we are experiencing now. The way how we are in Uganda is that usually we run like the private sector runs its own business in some way with minimal interference from the what?
It is demand-driven
government.
And profit-oriented.
Exactly.
Yes, yes, yes.
So what this now happens is that if there is some bit of, let's say, high demand, every person would want even to increase the price on the commodity that he has. I somewhere think that there has been sort of, much as they discussed, but some of these commodities which refer to as life-saving, I don't think it warranted the prices to go as high as that. But I think also that that's what I noted first, the first point I made, that if there was the way of having coordinated and control of the supply, because if you hear what the different players in the private are saying, is that which are charging so much because the price of getting it is actually high.
The cost of production
exactly.
is so
So
high.
there's the reason I think I've had actually some of the conversations with and engagements with the private sector. People will they have been actually saying that the cost of production, the cost of acquiring it, not production, the cost of acquiring this oxygen has gone high. And they were quoting some figures of where there have been changes in, for example, the amount they used to pay for the cylinders that they are getting now. So I think that's what has raised just some bit of what. And I would say that if there was, for example, they won't have, the ministry could be able to be on top of this and have that coordination of having, let's say, some of this, looking at this as a commodity, as we say, it is a life-saving commodity, then have control. Because at the end of it all, we fall back to government and say, you are the person to be able to assist us. So that maybe there could be the way of having, as you say, having that coordination and trying to streamline the supply of this, so that these people can, for example, have a fixed or a standard fee on accessing these oxygen. So then that would actually be able to curtail some of the people, the private facilities that would want to increase, because you have no reason of saying, I got this oxygen at a very high price. So that, I think, would have been actually played some bit of that. But somebody, because if he gets it, he will say, I got it at a higher price, and you cannot be able to ascertain whether this person, where he procured from, whether actually he procured on a low price and is charging an exorbitant fee. So I think that's to me what has not been a bit very clear. Having that control, having that coordination of this, so that the facilities, the private players do not give it as a reason of overcharging people for oxygen.
Well, back to Doreen, because we're still on the issue of accessibility, and here we're looking at price.
Yes, please.
Because if it is, even if we have enough medical oxygen, but if the prices are high, then its accessibility is actually going to be not there. Okay. So one would look at how should government come up with price control for the medical oxygen. I'll give an example of Professor Gwang, because when he came up with COVID-X, actually in some places it was going for 120, until he came out to say, look here, it shouldn't go beyond 12,000. So ideally he saved so many by coming out clear and say, look here, it is not for profit making. Yes, as somebody in the private sector, we sell it at 6,000, so you have 6,000 as your profit. There's no need of overcharging. So what are you doing as government, so that perhaps you can have a coordinated center for reselling this oxygen, so that most people can be able to purchase it as and when they want it? So
I will start with, there's so many questions in there, and I'm hoping I can remember to answer all of them. I'll start with it being costly for a wananchi, like you put it. We are giving it for free in our healthcare services. So wananchis, please go to government hospitals. It is for free. You do not have to pay for it. You do not have to pay for healthcare in our hospitals. So it is for free. That is number one. Number two, like he says, the demand has surpassed the supply. So the private sector is struggling. There's a conversation that happened between Ministry of Health and the private healthcare providers. And they said one of them, amongst many, was oxygen. And why it is expensive for them is because the demand in their hospitals is high. The number of cylinders they have are very few. So they need to buy the cylinders, that's a cost. Have it refilled, that's a cost. When they don't have the cylinders, the suppliers demand that you leave a deposit of a certain amount, so that's a very high cost for them. So when that conversation happened, it was brought into our projections as Ministry of Health. And when we made our proposal for plants, for buying our plants, we factored in private sector. When we buy our plants, we are going to give free oxygen to the private sector. So oxygen, the cost of oxygen is not going to be an issue for them at all. So we got their numbers, their projected numbers, put them in with our numbers, and now we are buying plants to increase our production, and then now it is going to be free for them. Now on the point of coordination, we have been supported by so many partners as a ministry, and we now have our platform that speaks to our demand across the country. Where we are seated, we know Moroto needs this many cylinders to meet their new demand. We know Arua needs this. So when we get these donations and when we buy as government, we know exactly where to put what cylinders, where, so that we increase the productions in all corners across the country. So we are coordinating that very well. When we get our plants and are able to give free oxygen, now we will add private sector, healthcare providers onto our list. And then we're able to know this hospital has this many patients, they need this much more oxygen, and then we are able to help them around. So at the moment, we are buying our own plants to increase production, and then we will be able to give free oxygen to the private healthcare facilities.
Well, George, just recently we were also told something which was actually very unfortunate, that some of the COVID vaccines that were given out was actually water, and it came from one of your high-ranking officers in government that look in the private health facilities. Some really did not get the rightful vaccine. Now, George, how do we ensure that really the medical oxygen being supplied in the private medical facilities is actually the rightful one?
I think that comes back to what we were mentioning, and I'm happy to note that coordination of trying to make sure that we have quality, but it's also not enough to people to access something, but they must have access to quality things. I think one of the issues which we all know is that the health sector, it is an institution, and it so happens that most of the time the people who work in the health sector, we are all, every person actually, has to have that issue of ethics. And one of the things, but also being supported by other government facilities, like government agencies, like for example UNBS, to make sure that we have the quality, but also Minister of Health playing that supervisory role to make sure that what is actually being consumed in the private sector is of quality. That's why you see even, it's not only oxygen alone, but even other products. The same thing you have heard of where they have arrested people that are selling fake drugs. So, but we have to continue to do that. That's, I think, the mandate of the ministry, to make sure that they do this supervision and have all this. And again, also, as Doreen mentioned, if we have that coordination, then you will actually be able to know, accrediting, for example, which plants and what type of oxygen are they producing, is it for medical oxygen or something else? So that it is very clear, and you are able actually to give, for example, the suppliers that are accredited by the ministry. So that now any person in a health facility cannot go to procure, for example, oxygen from any other person when actually he knows that this one is not accredited. And this actually happens even for other commodities. Let it be testing kits, let it be what. They are always just having some accredited suppliers or accredited items that a person or the people in the private sector have to procure, and they have to be actually meeting particular standards. Maybe during
maybe I can supplement.
Yes, before you can supplement, because he raises a very key issue, because we are looking at standards and quality.
Yeah, that's
and just recently, even so that COVID, Professor Guang came out and said, look here, if the rightful labels on the COVID that we've made is this. You know, Uganda is not short of unscrupulous people who will actually need to make a living out of any situation. So now, let's look at the safety of the oxygen, of the medical oxygen, the standards, and he talks about accreditation. So what measures is the ministry putting in place?
Just so I can relieve us of any anxiety on that. When we got a shortage because of the increase in demand and moved to have it supplemented, we did not take oxygen from everyone, because out there they are making industrial oxygen, which they use for different things. So we didn't go to pick it before we test it. So I told you it's now a drug. So National Drugs Authority has particular standards that it looks for. There are particular boxes that have to be ticked before you can be accredited to give us oxygen. So they visited all these plants that say, we are willing to give you free oxygen. So they visited, they checked every parameter that is supposed to be ticked, and for those who are not meeting certain parameters, they say, now you need to twist this, turn this, and give, and then you will be able to produce this. So they checked, they standardized, they did everything it requires, because when you're giving oxygen in the industry, there are certain impurities that you leave in there that are not, wouldn't affect you in your work. But for us in the health sector, those parameters have to be taken care of. So they said, increase this, improve, and they standardize particular industries that give us this oxygen. And so there's no one getting oxygen from any place that is not accredited by NDA. So that should be able to relieve us of that. That's not a worry at all. So we went out, we checked, we standardized. The ones who are not able to meet our standards were put off our list. So we have particular ones approved by NDA that are giving us that oxygen.
Well, still tuned to UBC TV, and we're looking at accessibility of medical oxygen during and after COVID-19, because COVID-19 has actually brought in the huge demand of medical oxygen and of course, other things that we're supposed to use so that we can boost our immunity so as to fight COVID or the coronavirus. Now back to George.
Yes.
Now let's look at the civil society, because civil society normally comes up when it is politics, but when it comes to issues of the pandemic, once in a while they will criticize government. But what should be the role in guiding the society on how to access free, because she says now it's now free, free medical oxygen?
Yeah, I think I would want just to correct that the civil society is not all about criticizing the government.
No, of course. I mean, most of the time, really, the society is always up there.
Maybe sometimes when they point out something that is not working out, then that's when maybe you realize that actually think that they are criticizing. And especially if somebody is outside, is able actually to see maybe where you have run short, the expectations, then they are able actually to do it, which I think is very healthy.
Yep.
Because if you look at the civil society, it does actually supplement government efforts. And given the fact that the mandate is upon the government to be able to provide quality health care to its citizens. So the civil society comes in to supplement what the government actually is doing. And I think the civil society has actually been working closely now with the government, especially in this time of COVID. If you look at, there are several technical working groups, and all these technical working groups, you find actually representation of of the civil society. There are issues like, for example, the plan. I was looking at the implementation plan for scale up of oxygen, medical oxygen, and I was like, maybe God was actually talking to us. Because if you look at this timing, it was 2018, 2018, 2022. And one of the things actually I think the civil society played a very big role to make sure that this is fast-tracked. So it was fast-tracked, and then we get COVID in 2019.
2019, yes.
You see? So you realize that sometimes actually it was looking at that, and we are happy that actually government listens some of these concerns that are brought out by by the civil society. There are also other things, because as I said, the civil society plays the role of supplementing government efforts, and they come up with the technical support, provide just technical support to where actually there are any of the issues where actually the government actually needs that support, or where we feel that there is some bit of gap, definitely within the framework of the Ministry of Health. Then you have also seen some of the civil society organizations that have directly provided some of these things. It's talking about cylinders. You have seen some of the civil society organizations being allocating money, buying actually and giving these cylinders. We have had some of the civil society providing the human resource directly, medical workers being actually supported and supported by by the civil society organizations, and all these actually coming to reinforce the existing structures of the government, to make sure that actually we are able to overcome this. Because if COVID-19 comes, it will not know that you work in the civil society or you work in so all of us are the what. And again, also the civil society exists for the communities. So that's the what. It's not like saying maybe fighting or what criticizing, but it is trying to look and say, I think we can do better with this. But also I think sometimes when maybe we are not aware, if the civil society is not aware of what actually is exactly happening or taking place, or maybe if there are some of the things that take long, maybe there are a bit of bureaucracies. In civil society, there are less actually bureaucracies compared maybe to government because of the many structures that exist. So maybe sometimes we might need and say, hey, why is it that things are not happening as fast as we would expect? So, but I think we have been working closely and in harmony with the ministry to make sure that all what we are doing is focusing on serving the common person, and is the same thing our concern for all. That is the person, the communities, that at the end of it all, we are able actually to be able to succeed and be able to put this challenge to rest.
Well, George, you brought up the issues of scaling up the production, and Doreen did talk about issues of most of the regional hospitals having actually oxygen plants. Now, one would also wonder, because the regional hospitals actually are very few. You find we have over 130 districts in the country, and one would imagine perhaps each district would have a referral, or you find that perhaps regions, the regional referral hospitals, maybe they may not be more than 10. So one wonders what happens to the health centers in the districts, the hospitals in the districts that are not at that level of regional referrals. How is government helping them? Because ideally, COVID is not only in urban centers; it is actually it's now everywhere. Now, the other issue I also wish that you should respond to is that there has also been, I should call it a vice, where Ugandans are good at creating artificial shortages. That somebody responsible will hold the thing and they say it's nowhere, so as to earn from that. Now you've given us hope that actually government is doing what it takes to produce medical oxygen that is going to be given out free. Now what those officers, your medical officers who are creating artificial shortages, what happens? How should they be reported and how do you handle them?
Okay, I'll start with the referral hospitals. Our healthcare system is very excellent. What is handled at different levels, it grows as it goes to specialized hospital. We have what can be handled at a health center 2. We improve it at a health center 3 and introduce maternity and other services. We improve it further at a health center 4 and introduce a theater and offer services around that. Now, what cannot be handled at health center 4, we improve it further at general hospitals. Now we are treating so many other things at the general hospitals. And then what can't be handled at general hospitals is referred to the regional referral. So the regional referral is very specialized. But there's what they can't handle at the regional referral that is very, very specialized that now we send to our specialized hospital of Mulago. So everyone is taken care of. What we have so far as the 15 regional referral hospitals, every regional referral mans a number of general hospitals. A district cannot have a regional referral because a regional referral has a certain population within which it's supposed to work. So that's why we don't have them that far. What we are doing now is we're having our COVID treatment centers at regional referral hospitals because the treatment of COVID is very specialized. It cannot be pushed any further down. So at the regional referral hospitals is where you have intensive care units. These intensive care units are what is handling the COVID right now, because out of the 100 people you will get with COVID, 80 will be mild cases. 20 will be what it will require admission, 20 of the patients. Out of the 20, 5 will be the ones that will need intensive care. So all that can only be done at a regional referral level, because now we don't want to spread the disease further than it should go when it comes in. So that is how our system has been built. On the issue of medical officers creating
artificial shortages.
Artificial shortages.
Yes.
I don't know how that works. But as far as oxygen is concerned, even when I would like to talk to the fact that we are scaling up. Because we've received these numbers and we've projected the worst case scenario, we have received funding from Ministry of Finance. We have received it, not that we plan to receive. So credit goes to our government for providing funding. We have received it and now we are procuring plants and cylinders, our plan A, our plan B, our plan C, to deal with that oxygen shortage, to increase our access to oxygen even further. Now, creating artificial shortage cannot be seen in government. I wouldn't want to speak to that because we know how much a plant can produce. If it produces 353 cylinders, we have a platform that says this plant here has produced 300, where did they go? So we already have a platform that coordinates where everything goes, what is coming in. So I don't think there will be an issue that someone will actually artificially hold back everything, as to cause an artificial shortage.
There have been cases where National Medical Stores has records that they've actually sent drugs to hospitals, and when patients go there, the drugs are nowhere to be seen. So let's get to, we go to George. Of course, she has given us that there will be a platform to share with the common man. That look here, this is what so far we've made, and actually this is the number of cylinders, oxygen cylinders that are available. So how do we make that information available? Because not everybody can access that platform. So as civil society, how do you help in creating awareness that look here, this is the state of medical oxygen in the country?
Yeah, I think this is a concerted effort by everyone. And being able to pass on information, actually creating awareness and sending information, that's part of one of the activities which people actually don't see as a very big and costly venture. But as we say, it is upon the responsibilities of everyone, and organizations have been coming up to make sure that you have information. This is, I think, part of the information that we are giving. That's what create avenues of where people can actually be able to have access to the information. We say information is power. So it is a continuous process, and the civil society is actually doing its best. One, to support and supplement government efforts in being able to push down the information through the different structures, but also supporting the efforts that are coming up from the ministry to make sure that we have all this information reach up to the up to the level. And I said, the government, actually in Uganda we have very good structures, as Doreen mentioned, health structures, very perfect.
And policies as well.
And policies as well. Now the most important thing is, how do we use them? I would say, when I look at the health structure here, coming right up from the national, then you go up to the community level where you have a VHT, who is the community health worker. So which means if you go through these channels, you will definitely be able to deliver the information to the last person, because this community health worker is actually always in touch with the community health workers, I mean with the community members. So which means you can actually be able to have this. And there are some of the things that actually have happened, some of the campaigns that have been very successful in trying to push down. Like if you take an example of malaria, I think we have done actually great in getting the information reached down, the issue of saying you must use what. But also very important, I think, is the issue of having the ministry still to, and at different levels, to be able to take up the responsibility of, one, supervising some of this information, but also supervising the private sector. For me, I think my observation would be that, yes, we may have like a liberal way of, let's say, for example, saying, I don't want, the government does not want to interfere with private sector. However, there are some of these things, like some of the commodities, the government has to protect the citizens so that they are not exploited. And at the end of it, you see, if you realize just, you note that actually our out-of-pocket expenditure, this is the money which the person pays, is a bit high. And the same thing is this, for to be able to foot the bills. So if we invest in giving information so that people are aware that yes, you are getting oxygen for free. So if you bill it on my if you give me an invoice and you are billing oxygen.
Yeah, of course, you're getting oxygen for free in a government facility.
Exactly.
Yes, because we need that correction.
Yeah, but also eventually we are going to be able to give free oxygen to
and now this brings me to you, Doreen, because oxygen for free in a government facility, but there is a person here who is in the private practice, and remember, it is demand driven and also profit oriented. Now, how are you working with the private sector, especially those the private health sector? Yeah, so that they can as well know that, well, they are supplementing government, the oxygen is given to them to give out freely, not to sell. to
Well,
the people?
that's what we are doing. We are planning, because when we bring in our own plants and are producing the oxygen, much more oxygen than we had right now, is when we will give the free oxygen to the private sector. And of course, we'll let the world know that we are giving free oxygen to private sector.
For now,
we are not.
We are not.
So, right now, the free oxygen you can get is when you come to our public health facilities. You will have free services like you've always had. But the private sector, the conversation we had and some of the commitments we made, one of them is that we should be able to produce it and give it to them for free so that they can have subsidized prices and everything. So that when we do that, the information will actually be available.
Yeah, we've also seen situations where actually perhaps somebody is bad off and maybe either on the ambulance or when they're still at home, they are advised perhaps to apply the oxygen on them. So let's look at oxygen for, is it available for people perhaps want to purchase the cylinders to have them at home just in case of an emergency? And perhaps how do they go about this?
No, it is not at all. Medical oxygen is completely dangerous to you if it's not administered by a trained health worker. You do not know how much you need. Well, everyone has a pulse oximeter and can tell. And then you are now at, say, the reading is 80. What are you going to administer? At what rate? So an excessive, and that's what happens. They panic and then they administer it in excess. And excessive.
And instead of saving life, you end up
You're actually killing yourself, because when you give yourself a high concentration of oxygen at a very high flow rate, your body goes in hyperactivity, producing so much energy, the byproduct being heat, then what is supposed to regulate you breaks down, and now you start losing your organs one by one. When you give it to a child, they get complete brain damage. That's how dangerous oxygen is. In our home-based care, oxygen is not part of that. You are not supposed to self-administer oxygen. You are not supposed to even go and buy it and have it in your home, because an oxygen cylinder is a bomb. It has concentrated oxygen. That means it's in there, and the moment you open it, it's very fast, going out very fast, but it's oxygen. It's a catalyst for fire. So right there, when you handle it badly, boom, you have a bomb in your house. So one of the things that we do not want and we do not advise anyone to do is buy oxygen and put it in their home. One, because it will blow. Two, because you're not able to administer it exactly the way it's supposed to be administered. So we don't advise that at all for home-based care.
Well, I can see time is not on our side.
Fast spent.
Back to George. Yes, in your view, what is it that government is yet to do so that we can see medical oxygen actually bringing down the cost of treating COVID-19 in Uganda?
Yeah, I think that's actually what she has already Doreen mentioned. The issue of saying if we can have oxygen subsidized, for example, for its facilities. So that calls actually for more resources to be availed so that we can have some of those initiatives of, for example, having subsidized oxygen to all private facilities, so that they don't use it as an excuse of using it to bill or getting just the clients or the patients not being able to access. The other thing is the issue of building on our structures. If you realize for the person to reach the level of needing oxygen, it means this person has been sick. Now, he starts with the home, the home-based management. Now, when he fails, this individual obviously will move. And I would actually strongly say that nobody actually should reach the level of having oxygen in the home. Because the person who is in oxygen, this person is very sick. Extremely very sick. Anytime this person can collapse. So such a person shouldn't have just what. So I look at that, what needs to be done is to streamline the linkage of referral at all levels. Yes, we are saying we have people we are promoting, or we have home-based care. So which means we must be able to monitor that. What happens when a person reaches that level? What will indicate to this individual that I need now to move from the home-based care to health facility-based, right? So we must put up just a mechanism of having that connection. And I think, to me, it is still a big gap, that we are not providing a platform, an opportunity for these people to have that, to keep in touch with some of them, which actually could be done. Because, like, for example, we have health centers at all levels, up to health center 3. If we can actually be able to make up a system of saying, let them have the basics, as I'm happy just to learn from Doreen that actually these facilities are getting, and even the VHTs, that's what she mentioned. So can we have that linkage of that, so that these people know, if I get just an issue, I'm able to run to the health center. Unfortunately, the person who is sick will not run to a regional referral, where actually we have all this set up. So to me, I think there is need for decentralization of care, build the capacity at those levels.
At district levels?
No, at the district, even at the sub-county level, where we have the health centers. Because when these people fall sick, they run first to those nearest facilities. They don't run to the what? To the hospitals. So which means if we can have that, strengthen, they know what to do, have them trained, get the basics, for example, having the pulse oximeters, which is able to tell, and then the person is able to note and say, if I'm a clinical officer, I've seen this patient, and this patient is getting to 90, then it means this individual needs to be transferred to where he can be able to access oxygen. Then the next thing will come are their means of transport. Then have the coordination of the ambulance, so that it can be able to refer this person to where this individual can do it. Because what is actually killing most of the people, the delay.
Yep.
The delay in accessing the services, the delay in accessing this critical care, then you will lose the patient.
True.
But if we have that sort of coordinated way, that clear, streamlined referral, I can assure you that would not actually be having a lot of pressure on the what. But because of delays, then the person who would have actually not gone to intensive will actually go to intensive because he or she delayed at home on the home-based care.
Actually, according to information that we're getting, is that some of the people really who have succumbed to COVID-19, who have lost the battle to COVID-19, is as a result of fear and stigma. That perhaps there is that fear that once you get COVID, it's like a death sentence. So, and here is where the civil society, you need to come in here to really give hope to the people. Now let's look at civil society, not at national, even at the community-based organizations. Is how should they here come in so that perhaps they can give hope to people and help them fight COVID-19?
Definitely, we have had some bit of reprogramming to make sure that, to the different civil society organizations have always work based on the need in the country. Because most of the civil society organizations actually work on what the government identifies as a big gap. So if there is always that gap, then the civil society come up to fill up that gap. And I would say that, as you rightly put it, stigma is something which, but I think now, because we have seen people who have gone, who have been actually sick and they have recovered. And as Doreen rightly put it, it is a small percentage that actually progresses to intensive care. So many people have suffered from COVID, even some of them who have not tested, they have got cured
and have recovered.
So I don't think it is something that really people need to fear, because fear actually does a great distraction on an individual. Because when you get fear, actually it will produce adrenaline, and adrenaline is not a good thing in the body of the individual.
Well, I think much. Thank you very much.
Just speak to something that he mentioned earlier about our structure system. Everything he has mentioned is beautiful because we're already doing it. We have now received funding and have bought kits for our VHTs who are directly in the community. These kits of theirs have a pulse oximeter, they have a temperature gun in there, they have masks, of course, for themselves, and other and gloves for themselves. What we want to understand is how far deep has COVID gone into the community. The VHTs are able to identify who is not well. The VHTs have been trained with a home-based care guideline, where they train and they test, they will check, of course, the first sign is if your temperatures are so high, then you are tested. And if you're a mild case, they will tell you this is how you are a mild case. When you get this, you've graduated from mild to moderate. Now you need to be referred. So you move to a health facility. The government has invested vastly in procurement of ambulances. We have so many now, enough to take care of us across the country.
Well, Doreen, you did talk. You did talk about the fact that very soon you'll be supplying actually free oxygen, medical oxygen to the private health practitioners. You know, anxiety kills a cat. So we just need to know how soon, so that really people can, because ideally the cost of treating COVID-19 actually in private health facilities is more than worrying. So perhaps they feel that if the oxygen can be provided to them freely, then maybe so how soon is that going to be?
I wish I could give you a date, but I need you to know that we are not the only ones fighting COVID. We are fighting COVID with the rest of the world. So while we are buying plants, the rest of the world is also buying plants. When we are buying cylinders, the rest of the world is buying cylinders. So we have quite a delay in our supply chain because we are dealing with this globally. So I wouldn't promise you a date, but that it's very soon. We are working within the supply chain globally to see how to fix it and take as much as we can as a country. So I don't think I can speak to a date when it comes to that.
Well, thank you very much. I'll give, in 30 seconds, your last message to the viewer. George.
Yeah, thank you very much. I would say that, end with the message of hope, that all different players are doing all it takes to make sure that we all come out of this well. The government has now procured vaccines. That's the only sure way of what we can do. Let people go and get vaccinated. And then also take the initiative of protecting oneself and plus the people around. Just what? Wear masks, prevention. I think that's, to me, which makes it, which will make the sense. It's not actually like the oxygen as we are talking to, because you don't know how you'll come out of the oxygen, but you should prevent yourself from going into that route of even requiring what? Oxygen. By wearing a mask, washing hands with soap, and again also avoiding crowded places. And if the vaccine just, since we are now getting the vaccines, go for the vaccine and get vaccinated. Thank you.
Well, thank you very much. Yes, Doreen, in 30 seconds, your last message to the viewer.
Okay, my message is that for us to prevent the demand for oxygen is for our fellow countrymen and women to actually prevent this. Don't be one of this, don't be a statistic. Don't increase the demand of health care to treat COVID when you can actually simply wear a mask. You can wash your hands, you can avoid parties, you can avoid crowded places, just so you can help your government. Now, when you float those small SOPs, that means your taxes have to be used to buy very expensive equipment to treat you. So that is not supposed to even be political or to be funny, because when you need oxygen, it will not be funny or political. So my cry to my fellow countrymen is just do the simple thing that you can do to help us not have big numbers and end up with this projected doomsday. You can actually live and COVID can pass without you ever having COVID. So that is my message to my countrymen.
Well, I must thank you very much, Doreen Kachompuga from the Ministry of Health, and also George William Barije, yes, from Perth, for really coming to be with us on the show, where we're looking at access to medical oxygen during and after COVID-19. Yes, when you protect yourself, you protect the nation, and when you fail to protect yourself, you're putting the nation in danger. Manda Kola Mazima is my name, saying bye-bye.